on the afternoon of June 29th, 2021. And we are getting ready to do surgery. All right, please don't move around too much, okay? You might fall off the table. Just kidding. We have our patients strapped down, at least the ones we like. I'm kidding. They all strap down. This is Dr. Deuk Laser. Can you hear me? Are you comfortable? No? All right, how can we make you more comfortable? Because I can't have you moving around trying to get comfortable during surgery. All right, so is your head extended too much or is it not supported enough? So is your head pushed back too far where your neck is hurting you, or is it falling forward too much? All right, so we'll take some of that frontal support out and let it sink down a little further. We're trying to get our patient comfortable before we get started. Is that any better? So it's really important if you do surgery, especially on an awake patient, that the patient's comfortable. Otherwise, they start moving around, and a moving target is always harder to hit. Okay? Are you better now? We're going to get started. This is Dr. Deuk Laser. That's my hand on your back. The first thing I'm going to do is give you some medicine that is going to numb up your skin. Unfortunately, that numbing part is a little bit uncomfortable. Okay? You understand what I'm saying? So if you're having pain, I want you to just say ouch, but don't move around, all right? This is the right side. Everybody agree? I'm standing on the right side. And on the right side, we're doing 3, 4, 4, 5. So I'm going to do a little bit higher than normal. That's just my finger, okay? You're going to feel a little stick and a burn. That's normal. That's the numbing medicine going in. You okay? That's just the numbing medicine. It's normal to feel a little discomfort. But that's numbing up the skin, and that's going to make it feel a little better in just a minute, all right? And then on the left side, we're doing 5-1. Everybody agree? This is the left side. Just try to relax your back a little bit. You're doing really, really good. Again, a stick and burn. Now, the deal is if I hurt you, you feel pain, just say ouch, all right? But don't move around. When you say ouch, I'm going to pay attention. I'm going to give you some more numbing medicine. So our patient is laying flat on his tummy, and he's had, how long have you had back pain for? A year and a half? Yeah. And prior to that, you had no back pain whatsoever? Okay. All right. We're going to get started. So right side, 3, 4, 4, 5. All in agreement? Sean? I'll be talking to my staff while we're doing this surgery. You're a little bit too much zoomed in. Sean? I think that's going to make it more zoomed in. You got to go the other way. That's good. All right, there we are. Maybe a little higher than I want to be. Let's go lateral. You get to just lay there and relax, okay? Just like you're on vacation. Don't worry, you'll appreciate my sense of humor later on when you go back and watch this. All right, so we got a lateral view on the x-ray machine. That means lateral is side view of the spine. And I think we're optimized for 5-1, but we need to really get 3-4 and 4-5 better. We can start with 4-5. Let's get those end plates lined up. Just, you probably need like half a degree at most. We're really close. All right. So for right now, we're going to, remember, you just let me know if you feel pain. Say ouch. Oh, it's too high. So I need to come down quite a bit. Blood pressure is good. All right. Let me know if you feel anything. And only if it really bothers you. That should be the fascia there. That should be better. So we need to see the sacrum. I think I see the sacrum, but I'm not 100% convinced. Shot. That's better. I feel convinced now. And maybe you could drop the table, maybe just half an inch. Good. All right, shot. That's a little more than half an inch. Can you go up half an inch? Good. All right, I think that looks pretty good. Thinking maybe even let's get the WAG done on the L45 because it looks like you're not really looking down the disc. You're pretty close. I have to give it to you, but I don't know if you just got funny shaped end plates. No. That's way too much in the wrong way probably. Sean? There's literally half a degree. That's perfect. That's really perfect. Yeah. I like that. I like that a lot. I'm very happy with that. All right. All right. Everything's going very well. Are you comfy? I think I want to go a little bit lower. Let's do some numbing. It's interesting. So we've injected about 12 cc so far. It's odd because I feel like I'm so low, you know, but it could be that his iliac crest is just a little higher than normal, and that's fine. Everyone's a little different. All right, that's looking pretty good. So step one of the surgery is to get into the disc itself, the disc that we're fixing, and to we call that the access part of the surgery, where you're accessing the area of the disc or the area of the spine that's causing the pain. So is that the newest shot right there? There we go. So where are we trying to access? We're trying to access a part of the spine that is in the back of the disc. And that part of the spine in the back of the disc, shot, is the part of the spine that's causing this patient's pain. And everyone else's pain when they have pain that comes from a damaged disc. And the part of the disc that's causing the pain is something called the annular tear. Shot. And the annular tear is a tear, like literally a rip, in the back of the disc in a structure called the annulus fibrosus. Shot. And the annulus fibrosus is normally a part of your disc that holds the jelly in. And the jelly we call the nucleus pulposus. So you got are you pulsing? You got the annulus fibrosus, which is a wall around the disc. Shot. You okay? Just about done with the first one. Let's get an AP. So an AP is another view, another way of looking at the spine using the front to back. We call it anterior posterior. Anterior means front, posterior is back. So we use a combination of different views, front to back and side. AP is front to back, lateral is side. That's perfect. My gosh, what a beautiful spine he has. Look at that beautiful spine. And I'm looking at the symmetry. I'm looking at the lamina, the spinous processes, the pedicles, the vertebral bodies. And it's just a really nice looking bony spine. The problem he has is not with the bones and the ligaments. The problem is with the disc, which is a cushion between the bones. And that's what we're here to fix today. All right. Shot? Yep, so we're going right towards that 045 disc. And again, a lot of times you can feel the herniation in the foramen. And I'm up against something here. It's giving me resistance. It's like almost like a rubber band, like a little knot in a rubber band. You can feel it. Okay? Are you okay? Now, for those of you anatomists out there, if you look at where we are in the neuroforamen, we're in the bottom. And that is one of the secrets to doing this procedure properly. Because the top half of the neuroforamen is no man's land and no woman's land. No children. No anybody's land. That is the area of the nerve root, and you don't want to mess with the nerve root. You okay? Everything's going perfect, by the way. Couldn't be better. All right, I'm going to go out and have a smoke, and I'll be back. Is that all right? I'm just kidding. Just kidding. You did know I had a sense of humor, right? Good. So far, everything is going perfect. Couldn't go better. You've honestly made it a little easy for us. Easier than normal. So that's because you're laying still and your anatomy is nice. So only surgeons really talk like that. Your anatomy is nice. I mean, anesthesiologists too, right? You got your laryngeal anatomy. You have a nice airway. Right? Yes, your anatomy is very nice. That's how you score points. All right. So we're heading towards the next disc, which is the L34 shot. And you see that bone in front of us is the facet joint. He's got a good sized facet joint. And I'm a little bit too medial, shot. Now I'm pointing a little too high towards the sky. North, we call it. It's not really north, but shot. But in surgery terms, we say when you're going too much towards the head, too north. Now the technical term is truly cranial or cephalad, but those are boring words. We like more interesting terminology like north. Everyone can relate to Cartesian coordinates. Shot. So we like to just say north. By the way, if you didn't notice, I do ramble a bit if you don't ask questions. It's going a little higher in the foramen than I want. We don't want to meet Mr. Nerve Root, shot. So I want to redirect and head a little south. Are you okay, my friend? All right, we are, shot, getting close to being done here on your right side, and then we're going to be able to go antagonize you on your left side. Shot. Yep. Any pain? Shot. Again, I can feel the herniation there. I feel the tear passing right through the tear. And let's just get one more AP X-ray. That means front back. Are you comfortable? Not too bad? Do we have any questions from the audience? Perfect. Let's go back to a lateral view.
None currently.
All right. So we're pretty much done with this side, shot. And now we can focus on the other side, which we've already numbed up a bit. Let me know if you feel discomfort, okay? Left, this is the left side, everyone agrees? And we're 5-1 on the left, correct? Actually, it's a pretty good entry point on the other side. You feel anything? Shot. And we are going to have to go lower. Just actually, you're probably okay where you are. It's not bad. And you got 5-1 lined up nicely. I'm going to need to aim a little bit lower, but I do like my starting point. So I'm going to redirect. And everyone's anatomy is a little different, but the things that are the same in everybody are the fact that everyone has that tailbone down there called the sacrum, and then the first disc above it we call the L5S1 disc, and that is the one that we're most interested in today, at least right now. We are treating 3 bad discs. Shot. It's too high. The angle is very important. Shot. If you don't get the angle right, you're not going to find the entrance, because the area that I'm working in is such a small little area, and there's literally a millimeter at most of space to work through. You feel that, huh? Yeah. You're fine. You're doing really good. I promise. Everything's going well. I really want to head south here. Shot. But I'm too far north. So he does have a high iliac crest. That's what he's feeling. High iliac crests are anatomical variations that make the surgery much more difficult, not easier. Shot. And so I need to try to deal with that. Shot. So far it's not too bad. Just taking us a little bit longer. Shot than normal. You okay? Shot. Yeah, I know. I apologize. You feel that in your back? Shot. All right, let's get an AP. Everything's fine. We're going to put you to sleep in probably 5 minutes, maybe 5 to 8 minutes. I need to run a few tests. But we're very close to being done with the first part of the surgery, which we call the access. Yeah. So let's go back to the lateral view. I think we're too far lateral. Where's my lateral? You got to save the lateral view. We're not terrible, actually. Not terrible at all. We just need to be a little bit more medial, I think. Shot? Oh, no, I am too medial. Fascinating. That's why. There we go. Shot? Uh-huh. Shot? Shot? All right, we should be very close there. AP. Let's see where we are. Once again, you have to use different views with the X-ray machine to know where you are. You cannot rely on a single view. You'll be wrong many times. So here I am too far lateral. I want to be more medial. It must be the transverse process that I was hitting, not the actual facet joint. I may need to start more medial, or at least aim more medial. Let's go back to a lateral view, please. So this is really, as I said before, this is, in my opinion, the hardest part of the surgery, is to get access to where you need to be on the patient to fix their spine. So, and that's what we're doing right now. And I'm really changing my entry point so that we can do that. Sean? Once again, he has a hyaliac crest, so accessing from the back here, his bone back here, is forcing me to start higher than normal and to get to the 5-1. So I'm having to compensate by changing my entry point and my trajectory. I'm just too high here. So let's try something a little different. I'm going to try to go a little lower. You're fine. Are you uncomfortable? Okay. I apologize. Shot. That's better. Shot. And shot. Shot. The trajectory looks pretty good. Shot. Let's see where we are. Let's get an AP. Remember, you can't just use the lateral view. The lateral view may say, hey, this looks great. But then you get an AP view and you realize you're not so great. You're really off target. And actually, we're much better this time than last time. We are actually on target. So by using the AP view, I now realize, hey, we're perfect with this trajectory. Okay, and what did I do? I had to modify my entry point. I moved it down and I moved it in. And that comes with many years of experience doing this. It's not something you're going to intuitively know to do. It took me a long time to figure that one out. So, are you shot? Are you comfortable? All right, lay still. So far, this is how much blood the surgery's lost, okay? Now he's bled more than normal. This is probably 5 mils, which is nothing. I mean, literally, you know, I've bled 5 mils, you know, scratching my foot or something. It's such a small amount of blood. Okay, so look here at the syringe. It's literally, actually hasn't lost 5 mils. It's more like 2 mils. So that much blood right there. That's how much blood he's lost. There's nothing. Okay? Normal human being has about 4 liters of blood. A guy like him, maybe 4.5 liters of blood. So that's 4,000 milliliters of blood. 4,500 milliliters of blood. We've lost 2 milliliters. Think about that. So that's nothing. Compared to open surgery where you lose 500 or 1,000 milliliters, you could lose 25% of the blood volume easily. Are you comfortable? Yeah? No back pain? All right. How bad is that on a scale of 1 to 10? I'm sorry, I really am. What's the highest that it went up to? Are you crying or laughing? Got it. So you don't want to curse? You can curse. We curse a lot here. I'm a cursor. So tell me, how high did it go? An 8. And didn't go above an 8. All right, folks, just so you know what we're doing, inside his back, way deep inside there, pretty much where these things meet, it's about 9 inches down from the skin surface. There are these 3 things that are causing his pain. They're called the discs, and there's 3 of them. And this is one of them. This is the L5 S1 disc, and then there's a bone here, and then there's another disc between this bone and the next bone. And these discs are really cushions between your bones. And really, to be honest with you, for many years, nobody really cared about the discs. They just thought they were just there. Who cares? But at Duke Spine Institute, we figured out the discs are actually why people are having pain, chronic pain. And it's the thing that doctors have ignored for hundreds of years, pretty much, except for a few. There have been a few that figured it out, like Dr. Cloward. Okay, he figured it out. He was playing with the back of discs during surgery, and he figured out the discs are the cause of pain. But that was 80 years ago, and nobody really paid attention. But there's a few doctors who understood the disc can cause pain. And Duke Spine Institute is one of those places, and I'm one of the doctors who figured it out. So in this modern day of 2021, we can now figure out which of these discs are causing patients pain by the physical exam and looking at the MRI before surgery, and then we confirm it during surgery. And we just tested the L3-4 disc. You can see it on the x-ray, and he said that that disc right there caused 8/10 pain. And that's his typical back pain that he gets. 8/10 concordant. Are you okay? Is it better now? So you can see the discogram. Whoops, the discogram caused pain, but it was temporary. And it only caused pain because that disc is so inflamed that once I kind of put a little pressure in it, it pushed on the inflamed area, the tear in the back that we're going to fix today, and it elicited his typical pain. Now, how high did that go? How high did that go? Is that what number out of 10? 10 being the worst pain of your life. Give me a number. A 9. Is that where you typically get your back pain? Huh? This is when you start to thank yourself for coming here to Duke Spine, because we just found the source of your pain. 2 discs, one was a 9/10, one was an 8/10, and they're both your typical pain. But if you're astute, which I know you are, you remember that we are not fixing just 2 discs. You're here for 3 discs. And as much as it pains me to have to do this, I find it necessary to confirm that we're doing what's in your best interest. Yes, it's music to my ears. All right, how bad was that on a scale of 1 to 10? You sure? Should we do it again? No, an 8/10, good enough. So, all right, now I have some good news for you, sir. You get to go to sleep, and when you wake up, that pain will be gone forever, unless you mess your back up. And then you can go back to all your friends in Pennsylvania and tell them, Dr. Duke Majan and Duke Spine Institute cured my back pain with a simple 7mm, well, 2 of them, incisions. Okay? And you guess what you're going to do? You're going to shave your beard for me. We have a bet. He said, if you get rid of my pain, I'll come here tomorrow with a shaved beard. Okay? And he'll be back with a clean face tomorrow. You'll see a video. All right, have a good night. Sleep. Count from 1 to 100 for me out loud. 1, 2, 3, 4, 5, 6, 7, 8, 9. I love it. If you get to 100, I don't pay the anesthesiologist. Keep going quickly. I think some of these patients actually believe I won't pay you. All right. Let's get that fluoro shot. What's wrong, guys? What's all the huffing and puffing going on? Everything okay? Jordan, are you getting a fluoro picture on the fluoro machine? Are you getting a fluoro picture on the fluoro machine? Good. So the fluoro machine's working, but it's not sending the signal to the TV camera in the operating room. All right, let's work on it. Did you hit 100? Did I hear you say 100? The anesthesiologist is like, oh, no, you don't. Go to sleep. All right, so we love to joke around because surgery can be fun. For the rest of the world watching, you normally don't get to see what happens in the operating rooms, but I can assure you it's not usually laughing and joking and merriment. But when the surgeries go well and the patients are doing well, then you can relax and you can throw back and have a good laugh. So the good news for this patient is we have confirmed that his back pain is coming from 3 damaged discs. And I can tell you right now, there's not a place in the world you can go that won't figure this stuff out properly except Duke Spine Institute. Why? It's simple. The doctors these days just don't understand the source of pain and how it relates to the patient's MRI scan and imaging studies and their anatomy. Truly, most doctors don't know that the discs are the cause of the chronic back pain or neck pain. We figured that out here at Duke Spine Institute by doing endoscopic surgery. And what we've discovered here today is we've confirmed through the discogram. Are we ready now? Is it working? Good. We've confirmed through the discogram test, which is an invasive test. You really don't want to do a discogram unless you're like ready to have surgery, Sean. But we've confirmed through this test that indeed this patient's back pain is coming from these 3 discs. I need to see a little bit more anterior. So can you drop the fluoro, or do you want to raise the table 1/4 inch? Good. All right. So I'm looking at the L34 disc, folks. That's the top one that's got that stain in it. And I'm looking for the guide wire shot. I'm advancing there it is. So I want to make sure the guide wire is seated, shot. Seated is a terminology we use, seated in the L34 disc. Before I take this shot, before I take this needle out. So I use the needle to gain access, shot. And by the way, look at this disc here that we're dealing with, the top one. It's quite interesting. Look at the herniation in the back of the disc. You see the foramen, that circle where it looks like a kidney bean where the wire went through? Here, I'll show you. Let me have a pointer. No, this. Take a shot. Shot? Is that your shot? Interesting. Okay, shot. All right, good. So take a look at this right here, shot. Just in front of this dilator. All right, right there, okay? Look at the dilator I just moved. That's not in the patient's body, by the way. It's on the side. But it's literally touching the herniated disc. You can see it looks like a lens, like a bulge. And that's not supposed to be there. The disc is supposed to end right. Shot? No. How did I get so far off? Shot? I wonder if the patient's moving. All right. See where the tip of the dilator is now? That's where the disc is supposed to end. But you can see there's a lens-shaped darkness bulging back, and that is the herniation. That's what we're here to fix today. Okie dokie. And now we actually will bring the dilator down to the disc. Was that a pretty good illustration there, Sean? Yeah. Oh, you like that? Good.
Yeah, it looked good.
Oh my God. You take that dropping the mic literally. Sean?
I'm not even dropping it.
What's going on with it? Is it shaking? Is there some wind in the room? Can we figure out technically what's going on? All right, so you can see right now this dilator is making its way down the guide wire. The guide wire represents a path of safety, a safe path. Of course, that's only if it is a safe path. That's why in the very beginning I told you placing the needle where you're going to put the guide wire through, that is the most important step. That creates the safe path. And if you don't do that part right, well, then this right now will not be safe. So I'm sure that what I did was right. And this is a safe path. And the guide wire is guiding the dilator. And the dilator tip is now pushing on the herniation. Okay? Why does the dilator look smaller now? Because it's further away from the X-ray emission source. Things that move away from the X-ray emission source become smaller. So we're ready to enter. Right now we're going to push through the tear that's already there, and that's where the herniation came out. So Zach, this is good for you to watch as you create the newest animation of the Deuk Laser Disc Repair. You can see that I'm going to push this dilator right through that tear in the back of the disc. And it's really going quite easily, to be honest with you. It doesn't take a lot of force because there's already a gaping tear there. And we're just passing right through it. Now, why do I use a hammer? Why do I use a hammer? Who knows? Luis, you know the answer. Why? More control. It's all about control when it comes to surgery. You want constant control. Okay, if I get on the patient, I start pushing this thing in like, then it could release suddenly, and next thing you know, it's inside his, stomach, and we don't want that. So, using a hammer, as brutal as it appears, is actually the safest and best way to do this. Basically create a small amount of force that is controlled and directed the way I want it to go, so that it advances this surgical instrument in a very small, millimeters at a time way. And by the way, with, I don't know if you're aware of this, but if you take your hands and try to push the tube in, then you could be, you want it to go this way, straight in, but you could be doing one of these or one of these or one of these. But with a hammer, it only goes one direction, straight in. So the hammer, as brutal as it looks, I get a lot of people commenting on it. The hammer, sorry. It actually is much safer than pushing. So that's why we use hammers. Bet you didn't know that. Shot. All right, you can see the tube is sliding down slowly. And that's fine with me. Never try to rush things in surgery. If you are rushing to, make your tea time or anything else, you're going to make mistakes. And that's not fair to the patient, because the patient should never have to pay for your mistakes that you make as a surgeon, because you're being an idiot. You're being selfish. All right, we are now have created a bigger path, a bigger, wider path to go from this outside world to the inside of the disc that needs to be repaired. And that first disc we're working on is L34. Thank you. You can put it on. It's actually that way. Luis has been helping me for years. All right. So we are now inside the L34 disc, where we pass through the tear that's causing all the problems. And we've got our scope light on, and we're heading down the rabbit hole. Okay? Now I'm flooding the chamber with liquid. All right? Things look a little hazy. Could be the blood. But there's your first piece of herniated disc right there. And I'm going to get my grabber in there and try to grab some of that out. The loose pieces of disc herniation are nice to grab out with the metal grabber. I really use two instruments this whole surgery. And I've seen other endoscopic surgeons use different instruments like drill bits. And I told you earlier in the last surgery about the radio frequency probe, which, the surgeon who developed and designed it, he gets basically royalties every time someone else buys one. And it's $500 a probe. And that's all good and fine, but if it was better, I'd use it, but it's not, you know. Sometimes surgeons, they develop things that really don't work that well, but they make money on it, so they promote it, even though it's not really best for the patient. I just do things that are best for the patient. I don't make any money on any of this equipment or instruments. I just do the surgery. The only thing we use is the laser. You're looking at it right now, that blue thing with a little clear tip. And the other thing we use is the grabber, which is scientifically called a pituitary rongeur. That's the surgical term, pituitary rongeur. Pituitary because it used to be used initially to grab tumors out of the pituitary lobe or gland. That's what neurosurgeons use. And since I'm a neurosurgeon, I get to call it a pituitary rongeur, and I get to use it. But we're not using it to take the pituitary tumors out. We use it in spine surgery quite often. As a matter of fact, pituitary rongeurs are most often used during spine surgery, more now in spine surgery than brain surgery. So, all right, we are inside the L34 disc. Remember, this is the one that was a, what do we say, 8 out of 10? Yeah. 3-4 disc was 8 out of 10 pain. And so when I'm done fixing this disc today, that 8 out of 10 pain that he's had in his back for the last 18 months is going to be gone permanently for the rest of his life. The only way people's pain comes back, and it's extremely rare, is when they re-herniate their disc, if they re-injure the disc. I've never seen the pain come back. In 1,300 surgeries, the pain doesn't come back ever unless somebody re-injures their disc. And I can say that because I've literally watched these patients now for 16 years, and we've looked at their charts, reviewed their data, and people don't have any of that disc pain ever come back unless they re-herniate the disc. I may get other sources of back pain or neck pain like facet pain, or they may tear the muscle in their buttock called the piriformis muscle and get piriformis pain, but they don't get disc pain coming back. And the other stuff takes different kinds of treatments to get rid of it. It's not surgery. All right, are you telling me there's no questions? That I'm just babbling?
We do have one question.
Good to know. What's the question?
A viewer is wondering what separates the Deuk Laser Disc Repair from a conventional discectomy.
Oh. Zach, you want to take that one? I'm kidding. So Zach is there, he's watching. Zach is creating a educational piece, an animation that's going to show you the difference. I'll describe the differences, and Zach, you're welcome to write these down. So the first thing that happens is the skin incision. So how do they differ? They differ in so many ways that I'm going to tell you all the ways right now. So Zach can incorporate them in his animation. The first way they differ is the skin incision. Number one, the location of the skin incision. My skin incision is off to the side, lateral. The microdiscectomy skin incision is in the midline. It's literally right in the middle of the back, either to the right or left of the midline, but no more than a finger breadth off of the spinous process. The second difference is my incision is small, 7 millimeters. That's all we need to get this tube in. The microdiscectomy incision is usually 21 millimeters, 3 times bigger. And that's if you do a minimally invasive microdiscectomy. Many surgeons don't know how to do minimally invasive microdiscectomy, so they do, big ones. So they're looking at, a couple of inches incision. So a much bigger incision for the microdiscectomy. All right, so then what's next? Well, with the Deuk Laser Disc Repair, after my incision, there's literally nothing damaged underneath the skin. I use a dilator, and the dilator spreads the tissues. So there's no damage to anything under the skin. However, when you're doing a microdiscectomy, the first thing you encounter after making that really big skin incision is you encounter the fat. And the fat really doesn't get damaged that much, but it does. And you get atrophy of the fat. So the fat dries up, dissolves away, and you get a sunken in area. Then you got to peel the muscles off of the bony spine. Those muscles are the ones that are attached to the spine. They're the ones that allow you to sit and stand. They pull your chest up. So the muscles are damaged with the microdiscectomy by the surgeon. They literally have to rip the muscles off the spine, and it causes muscle damage. You don't want muscle damage. It causes pain and scar tissue. And it also weakens your muscles. So that's another difference, is muscle damage with a microdiscectomy is extensive. Whereas with Deuk Laser Disc Repair, there is no muscle damage at all. Then once you peel the muscles off in a microdiscectomy, you've got this bone there called the lamina. And you can't just go through the lamina or between the lamina, you've got to remove the lamina. So every microdiscectomy is done with a laminotomy or laminectomy. So removing the bone in the back of the spine is called a laminectomy, and that's what happens with a microdiscectomy. It does not happen with the laser surgery because we're not removing any bone. So we don't make holes in the spine. Now between those bones is something called a ligament, specifically ligamentum flavum. That's the name of it. Flavum is yellow in Latin, it's yellow ligament. So the yellow ligament has to be removed in a microdiscectomy. So the surgeon removes the yellow ligament. That's not good, trust me. That causes bleeding and instability of the spine. That doesn't happen with Deuk Laser Disc Repair. We're not removing any ligaments. Then the next thing that happens is you have to take, in a microdiscectomy, you have to take part of the joint out, the facet joint. Remember that joint that we went past? We just glided past it. We left it alone. We didn't mess with it. In a microdiscectomy, the surgeon has to take half of that joint out. So now the surgeon has taken out the lamina, the ligamentum flavum holding the bones together, and the facet joint, half of it, 50% or more. A minimum of 50%, by the way. But many surgeons take out 80, 90%. So guess what that does to your spine? It causes it to wobble around, unstable. Okay, so instability. All right, so now we've taken out the lamina, part of the facet. And by the way, if you look at the code for a microdiscectomy, the CPT code is 63030. If you read the description, oh, by the way, you see that pink stuff right there? That's granulation tissue. That's what I've been telling you guys grows in from chronic inflammation. And it has little blood vessels which give it the pink color because that's blood, small little capillaries, and then it also has nerves, painful nerves. So any kind of pressure on that, like when you're standing up, that causes back pain, that's from that little pressure area, that little granulation tissue. Getting back to the microdiscectomy, now you have taken out the bone, the ligament, and part of the joint, the facet joint on one side. Next, you have to actually move the nerve root over. And here's where a lot of surgeons make mistakes. When they're trying to move that nerve root over, they actually cut it. And the patient ends up waking up with weakness in their leg or spinal fluid leak, CSF leak. All right? So with the Deuk Laser Disc Repair, we don't damage the nerve root because we don't need to move it over. We're working in an area of the spine called Cambin's Triangle. By the way, that's a piece of herniated disc that just floated by. We're working in Cambin's Triangle, which is underneath the nerve root. So we don't have to move the nerve root over. We don't touch it. We just come in underneath it. There's the tear, by the way. See that tear right there? All right. This part of the surgery is called the annular debridement. So the annular debridement, where I'm cleaning up this tear, this is what gets rid of the back pain. This is not done in a microdiscectomy. Why? Number one, the surgeon doesn't even know they're supposed to do it because they're not trained to do it. And number two, you can't see the tear when you do a microdiscectomy. It's too far down in the hole, covered up with blood, and they don't have the endoscope. They're not looking at the tear like we are. The only way you can actually see the tear is to do endoscopic surgery. Look at that herniation that's trying to get out of there. That thing was outside. We shoved it into the disc when I put my dilator in through the tear. And that guy is just loose as a goose on a caboose. There it is. You see that? I didn't even have to do anything. It just came out. It was trapped, though. Earlier, it was trapped in the posterior annular tear, and that's what was pushing on the nerve roots. It's just an amazing surgery. So it's also, microdiscectomies are not bloodless. There's bleeding. As a matter of fact, If your surgeon is totally incompetent, which about 50% of the spine surgeons are, there's going to be a lot of bleeding. And that bleeding, by the way, guess where the blood goes? It goes to the bottom of the hole, and that's where the herniation is. So it actually keeps them from seeing what they're doing, which is why so many surgeons end up accidentally grabbing the nerve or damaging the nerve during surgery, because they can't see what they're doing. Here, do you see any blood? Nope, because the Deuk Laser Disc Repair is pretty much bloodless surgery. So the blood, believe it or not, the blood can be the biggest enemy of a surgeon. Now, if you talk to surgeons that are older, the ones that operated back in the 50s and 60s, guess what? Blood was the #1 biggest complication of surgery. Why? Because they didn't have any tools to stop the bleeding. All they did was tie the bleeders off. They would literally grab a hunk of tissue and wrap a suture around it and tie it tight so the bleeding would stop. I mean, we laugh about it now, but that's how they actually got hemostasis years ago. So that's not what they do for microdiscectomies, obviously, but microdiscectomies, there's lots of bleeding, and that blood goes right into where the surgeon's trying to work, so they can't see what they're doing. So the visibility is extremely poor with microdiscectomy. Look at this visibility. Okay, think about this. The tube here you're seeing from side to side is 7 millimeters. 6 millimeters on the inside. 6 millimeters. So look how good we can see 1 millimeter. This laser fiber is 0.5 millimeter wide. 0.5 millimeter wide. So that's 0.5 millimeter. Look how good we can see it. So the visibility with the endoscope is 1,000 times better than microdiscectomy. I can see everything, and that means that the surgery gets done safely without me accidentally cutting something because I couldn't see it really well because it was buried in blood, or because I couldn't see way down the hole. Okay? Go watch a microdiscectomy online and you'll see what a difference. This is a piece of herniation. Like, we're literally in the herniation. That's what makes it so easy. And because we're in the herniation, we're in the part of the disc that's already damaged. We're not causing more damage. We're actually going into the damaged area of the disc. Microdiscectomy, they don't go into the damaged area. They go behind it. And they come up on it by removing all this normal stuff that you don't want them to take away. So why don't surgeons talk about that? Because it's quite literally all they know, and they think that nobody else is doing anything different, so it's just, that's how it is, you know? They just believe in their mind that it's okay to do all that collateral damage to the patient's body because they're not aware there's a better way to do it. You know? It's like these people that go out and kill whales in the ocean. They spear them, harpoon them. Why? Because they're hungry. They want to eat. But imagine if they had a source of food that wasn't a whale. Then they could leave the whale alone, right? And we wouldn't have this problem with overfishing with whales. In other words, if there was an alternative way to do it, then they would realize just how bad their ways were. But, you know, go try to tell an Eskimo who hunts whales, and they've been doing it for 1,000 years, try to tell them what they're doing is wrong, they won't understand it. Because that's their way of life. That's the way they did it. For 1,000 years, there was no other way. You eat whale or you die, or polar bear. But the point is that until you know there's a better way to do things, you don't realize how bad what you're doing really is. And the problem is all these surgeons around the world that do spine surgery, they don't know about this better way. That's why we broadcast, because we're hoping they can actually see it and understand just how much better it is for patients. The results are better, it's safer, the recovery is immediate. By the way, we had somebody email in, how long is the recovery for the surgery? The recovery is literally 1 hour. And then you're done. You're up walking, you're just being normal. You can go shopping in an hour. All right, you'll be a tiny bit sore, a little soreness, but you can't drive because you had propofol, but you can literally do whatever you want, except you can't be, you know, playing rugby or football or some sport right away. And you just got to be careful not to carry anything too heavy for about 6 weeks. You know, really the first year, you got to just be super careful. All right, after 1 year, the disc is healed all the way. That's another piece of herniation. Man, this has taken a long time because this is a big injury. Look at the tear right there, the blue thing. That's the dye we put in, and it's outlining the tear for me. This is still the first disc. So it's taken a while because the tears are so big and there's so much herniation in the tear. So the laser can only do so much. I can't really ramp it up. Of course I could, but then it would start burning things. Like the tissue would start charring, and that's not good. So we want to deliver just the right amount of energy to break up the bad tissue and release it and get rid of it, you know, suck it out. But you don't want to start creating char. Char tissue actually increases the chances of infection. You'd have to have a lot of char, which we don't ever have. All right, we're just about done with this disc, getting close to the end. This is kind of some more granulation tissue right there. You can see it, the pink stuff. That's where the pain comes from. Those nerve fibers, those pink areas have nerve bundles, nerve fibers in them that are pain nerve fibers. And they carry those pain signals up to the brain. Zach is working on an animation that's going to show you what we're talking about. It's going to be the first of its kind in the world. It's going to be released probably, what, Zach? I mean, we could release what you have this week, you know, just showing how the signals get up to the brain. We could probably release that this week, right? I know Zach's there listening. Oh, God.
Sorry, we could, but we probably want to take a little more time just to get everything fully ready.
All right, there you go. Thank you, Zach. So we're very close to releasing the first animations that we've been working on for months, that highlights and illustrates exactly how the tear in the disc causes pain. The kind of pain that everybody experiences: chronic back pain, chronic neck pain. And then we're going to do another animation that's going to show how we fix it with the laser surgery. All right, that's another piece of herniation there that I've freed up. It's kind of lateral in the disc. This one right here kind of broke apart into two pieces. Go back for the second half. Yeah. That little guy is stuck in there. It's what I call pump and dump. It's when I pump the endoscope into the tube, it creates a rush of irrigation that then dumps the herniation out right onto my lap. That's my version of pump and dump, and it's actually a good kind of pump and dump. Here's some herniation. Not like the stuff that happens in Wall Street, right? How's he doing? Good. All right. Well, we're almost done with this disc. Huh? Oh yeah, yeah. He does? To get back to a normal life. Yeah, I know. I could tell. I could tell. So he's 69 years old. He doesn't look 69. Right. Yeah, he looks very fit. Very fit. Again, you know, this surgery is not for everybody. It's only for people that want to get out of pain. That was supposed to generate at least 1 or 2 giggles. Yeah. Who doesn't want to get out of pain, right? I think, you know, everyone wants to get out of pain, but some people develop this learned helplessness. Anybody know what learned helplessness is? It's for my viewers. Anybody know what learned helplessness is? Who first described learned helplessness? Huh? You guys Googling feverishly. Stand by. Anybody know? It's a psychological term. It was, yeah, Pavlov. Pavlov. Pavlov was a scientist. He studied learned helplessness in animals, specifically dogs, but it applies to humans. They used to put these dogs in a room with a metal floor, and they would turn on a light and make a sound, and the dogs knew with the light and the sound something bad was going to happen. And this was back in the days before animal cruelty and, you know, PETA and all that. I'm not condoning what was done. I'm just telling you we still read about it in our books in medical school. So they would turn on a light, they would have a siren go off, the dogs would perk up, and then they would electrocute the floor of the pen, and the dogs would have pain going through their bodies from the electrocution. And they would try to jump and get away, but they couldn't because they were in a room with walls contained. So they did this experiment on these animals over and over again, and the first 10, 15 times, every time the light and siren came on, the dogs would get up and nervously pace and try to jump away from the electrocution, from the pain. But then, after a while, after a few weeks, they stopped trying. The light and siren would come on and they would just lay there and get electrocuted. I know it's horrible, but it illustrates an important point. And people are a lot like their dogs in that they just learn to accept pain and to change their behavior. They stop trying when they give up. So why do we broadcast? We don't want people out there to be like the Pavlovian dogs and just give up. We want you to know there's hope and that there's a way to cure your back pain, so you don't have to be like the dogs and just suffer every day. You can actually do something about it besides lay on the floor and wait for the pain to pass. You can take control of your situation, your life. You can regain control and you can get rid of it. But you have to act, and you have to act and do what's right. We're showing you there's an open door. Leave the room. Join these patients that we've treated. Get rid of your pain, you know. Through this educational video you're watching, through this surgery, through this other person's experience and their life, their choices to change their fate, you have opened that door to the Pavlovian cage, and you now can walk through the door and leave, or you can stay in there and get zapped the rest of your life. You make the decision.
But these dogs were confused. They start salivating. They think they're gonna eat.
I think Luis is having an aneurysm.
Yeah.
That's what my kids say. My kids say, "Dad, you're having an aneurysm." I'm like, "Do you even know what an aneurysm is?" And they say, "Do you know, Dad?" Of course, I'm a neurosurgeon. We treat aneurysms. All right. Any questions from our audience?
None others currently.
Uh-huh. So Sean, you're definitely not touching anywhere on the mic. You're just what?
Just turning it on.
Yeah, what's that? Is that when you turn it on? Maybe that's sending the that signal?
Essentially, yeah.
So we need a new, whatever, a new mic or what?
Maybe.
Maybe? I would say definitely. Whatever it's doing that, it has to be fixed. I can't tolerate it. Even if from my audience, I can't tolerate it. So let's get it repaired, or let's get a new one. Will you let Sunny know, please?
Yes.
Thanks. All right, here we are. This is the end of it. The end of the herniation. Why does the irrigation look like it's not flowing? Are we done on irrigation? You guys have the bag pressurized? Because it's not really clearing out the debris either. I think there's something going on with the irrigation. Did it just run out of pressure? Just about finished here. We're at the end of the disc, at the very back of it. You can see the pink end plate. That is L4. And then at the top at 3 o'clock is L3. I'm going to go lateral here. Just clean up the lateral herniation and tear. Alright, you see how important the laser is in this surgery. We don't just call it laser surgery for nothing. We actually use the laser. The whole surgery. So this is an important tool. Why am I getting all these air bubbles, guys? It looks like we're out of irrigation. Are we not paying attention? No, we're not good. I guarantee you we're not good. You may be seeing a little bit of irrigation at the bottom of the bag, but that bag is empty. Now I'm seeing flow. Tell me when I can proceed. We good? Thank you. Beautiful. So this is it. And once again, the reason this one's taken so long is there was a huge tear. Remember I told you the dilator went in really easy because the tear was so big? So a huge tear with a lot of nuclear material that needed to be removed. A lot of disc herniations are kind of older and they're more collapsed and the nuclear material is dried out, so there's not a lot of volume to remove. But here you've got all this juicy disc volume, all this bluish stuff that needs to be removed. And the more I get out, the better. At this point, I feel really comfortable that we've gotten all the part that is causing pain out. You can see the fibers of the posterior longitudinal ligament. And this is just the end of it right here. And I'm actually giving a little tug on the tube just to get a little bit more medial. That's all scar tissue right there, the white stuff, by the way, from inflammation. This is right inside the back of the disc. That's what you're looking at. People always ask me, well, when you remove the disc herniation, how much disc is left? We're not removing normal disc here. We're not removing anything that's normal. We're removing the herniation. The herniation, if you think about a toothpaste bottle, take the cap off and squeeze it. And that toothpaste that's come out of it, that toothpaste is gone. It's no longer part of the toothpaste inside the bottle. That's what we're taking out here. Laser off. We're taking away the part that's squeezed out. Yeah, there's no putting it back in the tube. And you don't want it back in because it's all grungy and bad anyway. It's not the normal disc material. All right. Standby scope.
Lights on, please.
So we've done one. And now we're getting ready to do the second disc. So I have to bring the x-ray machine back in for that. We'll use that again. But we're going to take this tube out of the first disc and put some pressure here, Louise. And I need some help with my lead again. I apologize. Okay, why not? Thank you, Zane. I'm not used to a man's hands on my waist, but you know what? I can take it. I don't want to be sexist. Thank you.
So you said you rode a bike?
I rode a bike in Maine. Yeah, we did some bike riding. I was there for 3 days.
What city?
We flew into Portland, Maine, and we went to a place called Bar Harbor and Acadia National Park, and we biked, in the forest there. Yeah. Nice. That's amazing you can remember that name. Hold this here. Madawaska. Yeah, a lot of that area has those Indian names, you know, like the American Indian names. And a lot of those Indians are not recognized tribes. Okay, we're doing the L45 next. I said they're not recognized because they don't have a casino. It's so true though, you know? It's like the government doesn't give a damn about the Indians that don't generate revenue. Seminole Indians? Oh yeah, give them the Hard Rock Cafe, make some money for us. But the other ones that don't have lands that have casinos, what were the names? we don't know who they are. We don't recognize them. I'm sorry, but if you know me long enough, you know I love to poke fun at hypocrisy and hypocrites. All right, here we are with the dilator at the back of the L45 disc. Once again, you can see just faintly an outline of the herniation now at the tip of the dilator, and that herniation is in the foramen. And, you know, most of the dye is dissipated. You can come off. So that dye is mostly gone at this point. And even at 5-1, you can see it's really gone. The disc below. Shot. And once again, we're advancing our dilator along the guide wire shot into the disc itself through the tear that was created by the patient with some kind of a traumatic injury. Now we're inside the disc with the dilator. Mallet, yep. Perfect. Goes pretty easily when you're in the tear. And now we're going to bring our, for those of you who don't know, this tube here is where we do the surgery, through this tube. So the whole surgery is done through a tiny little tube. It's called a tubular retractor. And we're going to put this tubular retractor down over the dilator. All this is FDA approved. I get questions all the time from people, is your surgery FDA approved? 100% FDA approved. Okay? As a matter of fact, in the United States of America, if you do anything to a patient that isn't FDA approved, they come get you late at night while you're sleeping or watching TV with your family. They bust through your windows. They take you down like a hog and tie you, and they run you off to prison. Okay? I'm not speaking from personal experience, but I don't ever want that to happen, so I kind of follow the rules. All right. I value my freedom too much. Point is, we don't do anything that's not FDA approved here at Duke Spine. Yes, thank you, Luis. Luis is my psychic. Here's some herniated material for you, Luis. You are welcome. Okay. We're getting ready to repair disc number 2, which is the L45 disc in this patient. It took us a long time to do the last one. I got to start up the irrigation. And there it is inside the disc. And all these start to look the same. As a matter of fact, they all are pretty much the same. The only difference is how much disc material is left, how collapsed the disc space is. But the anatomy of the disc is actually quite simple. If you do cataract surgery as a ophthalmologist, you realize that they all are pretty darn close to being the same looking. It's because most lenses are about the same and the cataracts look the same. So this is one of those structures in the body that's pretty simple in terms of its architecture. It only has a jelly center and an annular ring. Yeah. I should have had another slice or two of pizza for lunch. That's, lead would not be falling off my waist. So after Bar Harbor, we went to a part of Maine that was pretty much out, you know, where there's a lot of farmland. And we just biked out there in the country. Anybody have a chair for me? Thanks. Hopefully we'll keep this. I need the skirt pulled up again. I'm so sorry. That's all right. I thought I got it on there good, but this damn thing is just sliding down. My wife says I have a flat butt. Just leave the chair there. Okay. Thank you, though. All right. That should last me the rest of the case. So after we're done here, we're gonna head over to the recovery area and we're gonna take a look at our first patient. I think she's ready to go. Am I right about that? Chomping at the bit. My God. So all this, the stuff here, from right here over to here is all the tear. And it's just all scar tissue. It's just his body has built up, like, try to wall it off with scar tissue. Unfortunately, obviously it hasn't worked. But that's what happens when people put off getting these things fixed, is they build up all this scar tissue from inflammation going on and on and on. You know, when you look at a liver of a patient who's an alcoholic or a cirrhotic liver, it's just loaded with scar tissue. It's so firm and it's not nice and healthy. It's just filled with scar tissue. And this disc, this tear, is just filled with scar tissue. The same reason, chronic inflammation. You know, when you have inflammation going on in your body for a long time, it creates scar tissue where the inflammation is happening. And in this case, it happens inside the annular tear, inside the disc. And that's all this stuff right here. It's just literally a mountain of scar tissue that I got to deal with here. Look at that. That's kind of cool looking right there, you know, blue and white. But that's your tear. The stuff that's really white doesn't stain well with the blue. That's mostly the scar tissue. The stuff that's blue is mostly the nuclear material, nucleus pulposus. It's very acidic, so it binds to this dye. The dye binds to acidic materials, okay? There's basic biochemistry there for you. Any questions from our audience? Yes, no, maybe so.
We do have a question. One of the viewers on YouTube is wondering, when you go through the disc to reach the herniation, is it the good disc material that's being zapped out, or it's just the damaged?
That's a really good question. When we go through the disc to reach the disc herniation, do we go through the good disc? No. We literally enter the disc right where the herniation pokes out. So if you remember, if you rewind and go back and look, the tube, the dilator, the pointy thing, entered the disc right where this tear is, right where the tear starts and the herniation ends, basically. So we don't go through the normal disc. on the lower back. In the neck, for a cervical disc, we do go through the normal disc. And we use a much smaller dilator so it doesn't do any damage. Great question. So there's no normal disc damage during this procedure. We start at the bad area and we destroy that bad area only. See that right there? That, like, it almost looks like a glacier wedged between two mountains, two rocky mountains. That glacier is the herniation that's all scarred from chronic inflammation. See the white stuff in it? That's all the scar tissue from inflammation. This is the source of inflammation. This is the source of pain. Once again, Deuk Spine Institute's the first place in the world to treat this. We're the ones who discovered that this is the source of pain. Other people have treated herniations, but not the interposed nuclear herniation, this stuff. They treat the herniation that's outside of the disc, pushing on the nerve root or spinal cord. That's been treated for a long time. We're not the first to treat extruded herniations, but we're the first to treat the interposed herniation as a source of the pain. And you really can't cut this thing out, you know? If I take a sharp metal instrument and try to remove it, it doesn't come out. It literally just bends away from the instrument. You may get a little piece or two, but you're not going to get it all. So people say, oh, you don't need lasers. Yes, you do. The laser's the only tool, and I told you could use a bipolar, right? Earlier I told you about the bipolar, but the bipolar is far worse. It's slower, and it doesn't do as good of a job. And it's more expensive. But it's pretty cool though, because you really see the anatomy quite well. You can see the tear. This is it right here. This should not be here. That's what we're removing. That's why it's a debridement. It's not just a herniectomy or a herniatomy. It's an actual debridement. And in Deuk Spine, we were the first to describe annular debridement in the world. Go and look at PubMed. PubMed is the National Library of Medicine. And that's where all the scientists publish their results of their discoveries. And you'll see we are the first to describe surgery called an annular debridement. And this is what we're debriding right here, the tear. All right, any other questions from our audience? We're getting close to being done with this second disc.
None others currently.
How much, I'm just curious, how much energy do we use on that last disc? 38 watts, right? Or 38 joules. Yeah. Yeah. Yeah, 40, when you get to 40, it's a lot. So 38's pretty darn close. You think, you saw me do 60 one time? And it was one disc? All right, so there's your, potentially the record, 64 joules. We were here till 10 o'clock at night. Give me a break.
We were, because we started that patient at about 7, and then it ended up being such a massive,
All right.
long.
And that's what you remember, isn't it? When you, someday you'll be an old lady talking to your grandchildren. I remember when we operated 10 o'clock at night. Right? Forget about all the times you got to go home early.
But this one time,
This is one time, Dr. Duke Machen.
it just took so long. We went
Honestly, I can't even remember that. I'm. Wait. Are you sure I did the surgery? Maybe it was Dr. Patel. He snuck in and got a case in, or Luis. Maybe that's why it took 68 joules. Or some imposter. Oh no, I mean, what I do, what you're watching me do, believe it or not, is like fast. You know what I mean? Like I know exactly what to hit and how long to hit it for and how to hit it and how to move. If this was like my first case, we'd be here 3 times as long. When I was still learning, you know, like learning the technique, we would be here hours. Just be thankful. I've already spent those hours learning before you came. You know what I mean? Oh no, they have to be awake.
I had a patient that said that they had surgery when you could, they had this done at Parish years ago.
No, I never did this. I never did this surgery at Parish. Parish wouldn't buy the equipment. I went to them and said, hey, I want to start doing these 16 years ago, and I need this, and this. They, huh? Oh, you did? Oh, you remember me? No. Oh, Parish Medical Center? Yeah, so I asked them to buy all this equipment after I learned the technique, and it was a $2 million investment. They didn't want to do it. Yeah, I may have done a fusion or something at Parish. That's all I did. Fusion, laminectomy, microdiscectomy, all the usual typical surgeries, you know. But I never did laser there. They don't have any of this stuff. What's that? What's that?
That is a Chibrel is one of those Pavlov drugs.
Luis! Are you saying I can't talk about Pavlov anymore?
Yeah. What I remember about Pavlov are when the dogs start salivating because they know that they're gonna eat. So yeah.
Oh, well, he did a lot of dog experiments, but this was one where they electrocuted the floor.
That's what I'm saying. They were confused.
Yeah. Learned helplessness. The dogs just gave up trying to get away from the. Oh yeah, it is sad. This was before, before animal rights and before people acted like these scientists would just do all kinds of crazy experiments.
There used to be a show on Science Channel,
Yeah.
I'm a little nerd, but it was called Dark Science. And it was all about those things, and it was actually really interesting what they used to do. But one of them I remember, on there, they squeezed the heads of 2 monkeys, and they actually kept them alive for like 24 hours.
Oh yeah. That's the kind of stuff I'm talking about.
Crazy.
Yeah. Right.
I don't know how I watched that show. It was interesting. I learned a lot of medical things.
Well, a lot of these experiments went on because they were trying to understand how humans would do during warfare, like being in a trench for so long or being subjective to long-term warfare on the front lines, being in pain and suffering, and they wanted to understand what the troops, how they would respond. All right, fine. If they were tortured, captured and tortured, would they give up secrets? Blah, blah, blah. Anyway, I don't agree with the experiments being done, but we learn from them. All right, this is just about the end of this thing. I'm pretty much done here. And then we're going to do the last one on the other side. And this patient he's from Pittsburgh, right? Pennsylvania? How many joules have we delivered here?
So far,
That's not much. 21. So the other disc was a lot worse. At 40. This is about half as much energy, right? Since we're just about done. Okay. All right, any other questions? Did I answer all the questions, Sean?
Yes, you did.
Okay, I am getting tired myself. There we go. We're done. That's what happens when you go on vacation. You come back and get tired. All right, scope off.
Lights on, please.
And we're going to do our last disc. This is the bottom one. This is the L5S1. Again, this patient had 3 painful discs. For those of you out there thinking, hey, I've been diagnosed with 1 disc, you may actually have more than 1 disc that's actually damaged and causing the pain. Unfortunately, a lot of radiologists, they'll misread or they'll leave out the discs that are not massively damaged, you know, on the MRI. They'll leave out the little tears and stuff. They won't mention it. So a lot of people they end up getting their MRI report and they're kind of underwhelmed with just, wow, it's not that bad, you know. There's some bulging discs. When the doctor tells them, yeah, bulging discs are nothing, they don't cause problems. No, they do. All of this patient's pain came from bulging discs. This patient right here had bulging discs. The last patient had bulging discs. They had very small herniations. Not yet. So this patient's, I did it. This patient's pain, we have a sharp on the floor. Turn the light on. I'm just going to re-glove. And do you have any alcohol? I'll take a little booze. Just pour a little. It's fine. All right, I need to take this off. Let me just new gown, just to be safe. Thank you. So I'm going to re-gown, folks, and I'm going to pull up, let's see, can I pull up my lead? Let me think for a moment. Just bear with me as I re-gown. You mind pulling my lead up one more time? I just don't want to contaminate my hands. I know. Isn't that terrible? All right, you want me to come over there, Luis? No, I'll come there because I want to actually operate from that side. Yeah, my lead's good. You mind switching to the other side when we're done? Oh, he threw it away. All right. I've switched sides because our last disc is going to be done. Let's turn the lights back down. Is going to be done from the left. So I'm going to grab my guide wire and we're ready to go. This is the L5S1, the bottom disc shot. Perfect. So what we've seen so far is that the shot, let's just take a look, is that the L34 and L45 discs had quite large tears in the back of the disc, and that those tears were full of scar tissue from the body trying to heal it properly, but they couldn't be healed. I need an incision. That looks good. So his disc tear in the back of the L3445, his body was just like going crazy trying to heal it for years, by the way, years. In case I failed to mention that. Was there epi in the local?
Yes, sir.
Is there any more epi local left?
We have one. Any more?
Give me a second and I'll tell you. That's looking good. No, I think we're okay. Yeah, the tube will put enough pressure so that we don't need to add more epi. All right, so we're passing the facets on our way to this last disc, the bottom disc, the L5S1 disc. Shot. And I can actually feel the herniation right here. So, you know, when you look at the MRI, you can get a sense that there are big tears in this patient's disc. But you have to look at it, what are called T2 sagittal, which is the sagittal view, the side view shot. And you really need to look carefully at the foraminal view and the lateral recess view to see the degree of herniation. Shot. Take. All right, I think I'm in. I want to advance a little bit more. Once again, the tear here is very big. Very, very big. I can feel this thing just goes in so easy, and I can feel the resistance of all the scar tissue. So I have a feeling this disc is going to be a repeat of the last two. Same thing, big tear, lots of scar tissue. It's going to take probably about 20 to 30 joules of energy to, you know, correct it, correct the tear. Shot. We need about 15 minutes, we'll be done. Shot. Will you let our last patient know I'll be there in about 15 minutes? Shot. All right, that should be it. Take that. So, can you get a good view here, Sean? Get that out of there.
Of what? The scope?
Yeah, the back.
Yes.
Yep. Let's get that fluoro out. Perfect. Now you can see over here on the right side that we have a 7mm incision, right? And we fixed the first two discs with that one. Now we're going to do this last bottom disc on the left side. The reason for that is this patient, I believe their left leg pain was coming from this bottom disc, so I want to go on the left side. And the right leg symptoms were coming from the upper two discs. So I do need another ray around my wrist. So we should be wrapped up in about 10 to 15 minutes, hopefully. So I need my endoscopic view up there. Okay. Yep, same thing. You can see a giant tear. You can see a lot of scar tissue, collagen. Scar tissue, by the way, is made of collagen. All right, so I'm going to drop my lead. Can you grab my lead for me? It's just not wanting to stay on. And we're done with the fluoro, so. All right. Here we go. Piece of herniation. You know, a long time ago when I started doing these cases, I was actually collecting all the herniation material, and we would measure it, you know, with the pathologist. They would measure it afterwards. And we actually published how much disc material was in a typical herniation. And that was part of our publication. I can't remember the volume, but it was, it's in one of my papers. But we figured out it was less than 5% of the total disc volume. All right, what's dripping? Let's see. Okay, good. All right. So here we are, our final disc. This is the tear. We're cleaning it up. We call it a debridement. In surgery, when we debride a tissue or an area, we're getting rid of all the inflammatory tissue. That's why I decided to call it a debridement, because it was mostly inflammatory tissue and whatever the foreign body is that's causing the inflammation. So a debridement means removing a foreign body and the inflammatory tissue that results as your body reacts to that foreign body. Foreign bodies can be metal or plastic or wooden. They can even be, you know, infectious agents like bacteria or viruses. So what a beautiful debridement. Let's see the grabber. Standby laser. Once again, the grabber is a pituitary rongeur. It literally has a little mouth that grabs things. And the sides of the mouth have sharp edges, so it doesn't just grab, but it grabs and cuts. A lot of people don't know that. I could show you the structure of it, but it's like a cup with a cutting mouth. I was lucky enough to operate with Dr. Albert Roten, the chairman of neurosurgery at Shands, when he was chairman, when I was doing my training there. And I just remember watching him take out pituitary tumors with those rongeurs. That was my first experience as a surgeon using rongeurs. The pituitary rongeurs was actually taking out pituitary tumors with the man who is considered by most of the world to be who was the leader in pituitary surgery. All right, coming out. Why is it so white hazy? I mean, I don't think we're overexposed. Is it just debris? Or is it air bubbles? The irrigation's going good. It kind of reminds me of the smog in Los Angeles where I went to med school.
They say we don't trust any air we can't see.
Right? That was one of the main reasons I got out of Los Angeles, was the smog. When you live in that pollution every day, it weighs on you. And, you know, all your airway passages are full of black soot. It was just disgusting. I don't understand how so many millions of people can live under those conditions. So unhealthy. I wasn't going to bring my kids up in that environment. I know a lot of people don't have a choice, but if you have the opportunity to live with beautiful, clean, fresh air, please do. You know, the one city in the world that's kind of ironic is Buenos Aires in Argentina. I remember I went to Buenos Aires, it must have been 86, 87, and I was amazed at how bad the air was. It's the worst air quality I've ever seen in my life, worse than Los Angeles. Has anyone ever been to Buenos Aires? I don't know if it's changed or if it's gotten better, but back in the 80s, it was literally, you could not see one block down the street, one block, because the smog was so dense at one block. Yeah, the smog traps a lot of heat. San Fernando Valley used to get 110, 120. Sometimes in the summer, that's where we used to hang out with our cousins. I remember we used to run track and field in LA, and my God, there were times when I couldn't even breathe because the smog was so bad. All right, this is our last disc, and we're just about done. You can see again there's a lot of white granulation or scar tissue. As a matter of fact, the more white the tissue is, the more mature the scar tissue is. In other words, more advanced, the more basically without blood supply it is, because scar tissue is relatively avascular. Just about done. Perfect. I'm done, so I'm gonna head over there and we'll do our video. Huh? Good. Sean, you wanna let's just take our last questions if anybody has any, and then let's head over to the recovery area. We'll end this broadcast and we'll go check out our last surgery and see how she's doing, assuming she lets us video her.
All right, there are no other questions right now, but I'll ask you if they're due come up.
One of our viewers had asked last surgery if I could answer, how long is the recovery? The recovery is 1 hour, literally 1 hour. You can walk out of here in 1 hour if you wanted to. You just can't drive a car today because we do anesthesia and we're not allowed to let you drive. But you probably would feel like driving about 2 hours after surgery, because the medicine we give is gone right after surgery, and it doesn't affect your thinking. It's just it's very clear. You feel crystal clear thought. It's called propofol. It's an amazing medicine. So for those of you wondering, when we do our broadcast, the patient will not have any pain medications. We're not eliminating their pain with medicine. We're eliminating their pain with the surgery. So when we see this next patient, whatever pain relief she has is because of the surgery, the Deuk Laser Disc Repair, not because of drugs. All right, I think this is it. That's it. You can see the epidural space with some fat there at 12 o'clock. And remember, this is the bottom disc, the L5S1. We're pretty much done. By the way, I'm one of the few surgeons in the world that do endoscopic L5S1, transforaminal. Most surgeons don't know how to get into this disc. The ones that do endoscopic surgery that's transforaminal, they actually go interlaminar for 5-1, meaning they don't even try to do this. They actually go through the lamina which is again not good. I never finished the last surgery when they asked me the difference between Deuk Laser Disc Repair and microdiscectomy. The other thing about microdiscectomy, besides after we talked about potential damage to the nerve, is that microdiscectomy doesn't repair the annular tear. It only removes the part of the herniation sticking out against the nerve root. And all the work I'm doing here, none of that is taking away that herniation. Because most of our patients don't have a big herniation pushing against the nerve root, so they wouldn't even be offered a microdiscectomy. It's not an option. Okay. Off. We're done. That looks good.
Lights on, please. Lights on, please.
Scope off.
Scope off. Thank you.
Okay, we are done, folks. Any questions, Sean?
Nope, that's all of them.
All right, very good. So we did both sides. You can see the incision was 7 millimeters. Luis put a little pressure. It's been a pleasure, and thank you, everybody. Great work. I guess I'll call our EBL 2 mil. Oh, I love this pen.